The neuromuscular diseases, we're going to discuss the big ones, spinal muscular atrophy. This is an anterior horn cell disease. People like to compare it to Lou Gehrig's disease, except it's in children. This is an autosomal recessive disease. Look for the floppy baby. This is a major cause of having a floppy hypotonic baby. So they have denervation of the muscle and they develop atrophy. These babies with SMA, there are basically 3 types. The most common one is type 1, which is also known as Wernicke-Hoffmann disease. Type 2 has a later onset and a slower progression, but ultimately the same outcome. And stage 3, or type 3, is known as Kugelberg-Vielander disease, a much later onset, usually in adolescence, but again, same outcome. It is autosomal recessive. Patients will have a progressive hypotonia. They become very floppy. Look for fasciculations of the tongue. You can actually see the tongue kind of quivering in the baby, and they have very alert-looking eyes. They will have feeding difficulties. They eventually die from respiratory problems, either aspiration or recurrent pneumonias, because they can't cough up secretions as they get weaker and weaker. But look for the tongue fasciculations. They will have absent deep tendon reflexes. Again, they look very bright. The only thing that they can express is their eyes. They look very bright. The children with the infantile, or the type 2, will have normal, again, speech. It's just the same outcome. The best test to diagnose spinal muscular atrophy is the genetic marker. So you order blood for the SMA gene, and that gives you the diagnosis. Don't worry about doing nerve conduction studies, things like that. The best test now is the SMA gene marker. You can do electromyograms and muscle biopsies, but the best test is listed there. There is no cure for this disease. Myasthenia gravis is an immune-mediated disease, one of these autoimmune type phenomenons, where there are antibodies to the acetylcholine receptors, so that prevents the acetylcholine from binding to the receptor. Look for ptosis. Now, we talked about congenital ptosis, but this is a little bit different. Look for ptosis and look for extraocular muscle weakness. So you have a patient do something repetitive and they get tired very quickly. And that's the hallmark of the disease. They can develop dysphagia and facial weaknesses. They can have poor head control and limb girdle weakness. It can progress to actually involve the muscles of breathing. There is a transient neonatal myasthenia gravis. This is babies that are born to moms with the disease. They may actually need ventilation because they do have the muscles of breathing are affected. They may not do effective breathing, and so they may need ventilation. Then the antibody tends to wane, and the patient gets stronger, and they can get extubated. There's no risk for developing myasthenia gravis if you have congenital disease. It's just basically that some of the maternal antibodies have crossed. The EMG is diagnostic in myasthenia gravis, and you'll see that with nerve stimulation there's a decreasing response because of the muscle weakness. You can also have acetylcholine antibodies, and you can always have to do a thyroid profile because that's part of your differential diagnosis. Here is a patient that has myasthenia gravis, and you can see the ptosis here, and then you can actually reverse it and see how this eye the eyelid is higher up. So if you give them a reversal agent such as edrophonium or neostigmine, you then get reversal. So the patient, again, have them do something repetitive. As they start getting tired, give them the edrophonium or the neostigmine. All of a sudden, they get their energy back, and that helps you make the diagnosis. The management, mild myasthenia really doesn't require any treatment. You can give them cholinesterase inhibitors. That helps increase the levels of circulating acetylcholine that are available to go to the receptors. In the severe cases, since it is an autoimmune disease, you can give them steroids, and that does help slow down the response. If there is no response, patients can receive immune globulin or plasmapheresis. And thymectomy, removing the thymus, is very helpful if they have high titers of the antibodies and if they've had symptoms. These patients that have myasthenia gravis are a special subset of concern for anesthesiologists because they do not tolerate neuromuscular blockers very well, and they have really prolonged effects from it. And also, aminoglycosides will prolong the effect of these neuromuscular blockers. Charcot-Marie-Tooth disease is a peripheral nerve disease. They will have atrophy of the muscle because of the peripheral nerve not stimulating appropriately. Sometimes they'll present with gait disturbances at around age of 2, and most of them will have, by late childhood and early adolescence, will have presented with signs and symptoms. They get clumsy and start to fall. Since the muscle is now wasting, they have what's known as the stork leg appearance. These patients can actually, sometimes you can palpate the perineal nerve because of the atrophies. And they have what's known as the claw hand deformity. So they'll hold their hands basically in this position. This is a progressive disease. There is no cure for it. You try to brace the extremities and use orthotics to help. They will have decreased nerve conduction velocities on studies. And you can do a sural nerve biopsy, and that is really diagnostic. So you do the nerve conduction first, then the sural nerve biopsy. Guillain-Barré, very common to come across this on the exam. It's one of these it's an ascending paralysis. Remember we talked about not giving babies honey in the first year of life so they could get botulism. That's a descending paralysis. Guillain-Barré is an ascending paralysis. It's referred to as a post-infectious polyneuropathy or radiculopathy. And so many times you will see a preceding viral illness. They're getting over that, and now they start having weakness. It'll be an ascending paralysis, and it will be symmetric. Very important to remember that. It has been associated with Campylobacter infections as well, but remember it's an ascending symmetric paralysis. The progression varies. Sometimes it's over several days. Sometimes it can actually last for several weeks. These patients will lose their deep tendon reflexes. Very important to remember that. They'll have loss of deep tendon reflexes. It can affect the muscles of breathing, and these patients may actually need to go on ventilator management. And usually after 2 to 3 weeks, they have a spontaneous recovery, and you can see them getting stronger. They can come off the ventilator if they've been on it. Every patient with Guillain-Barré requires a spinal tap. Lumbar puncture will show an increase in the cerebrospinal fluid protein. However, there are no cells. So it's not going to be suggestive of meningitis, and this is very particular for Guillain-Barré. So a spinal tap reveals few or no cells, but an elevated protein. They will have reduced motor nerve and sensory nerve conduction. Patients, the treatment is going to be supportive. They all need to be admitted because you have to gauge the progression of the disease and monitor them for respiratory insufficiency. They may need immune globulin to help treat the disease. They also have tried plasmapheresis and steroids. These are various modalities. Duchenne's muscular dystrophy, this is going to be present only in boys. It is X-linked recessive, so look for it in boys. You'll see some motor milestones that are reached, and then the patient will lag and start to have loss of motor activity. Sometimes a subtle sign is poor head control in infancy. Certainly by the 2nd year you will see some limb girdle weaknesses, and look for what's known as Gower's sign. This is where the child who is playing and tries to get up basically has to crawl up on himself. So you'll see them pushing themselves up like this because of this limb girdle weakness. They also can develop what's known as a Trendelenburg gait, which is a wide space gait. You'll see pictures in a second. They develop what's known as pseudohypertrophy of the calves because of proximal muscle wasting. It's a limb-girdle disease, they'll have proximal muscle wasting. This is a uniformly fatal disease. Patients will eventually die from respiratory insufficiency. They will be wheelchair-bound by the time they are, usually 10 to 12 years of age. This is an example of pseudohypertrophy of the calves because of proximal muscle wasting. So these look really big, like he's been working out. It's not because of that, it's because they're losing muscle proximally. This is what's known as Gower's sign. This is the child, because of that limb girdle weakness, has to basically crawl and push up on himself to be able to stand up properly. This is a typical posture that they have because of the muscle weakness. And these kids, you can see, basically he's starting to stick his stomach out a little bit more because of the way the spine is moving as he stands up to achieve proper balance. They will develop respiratory insufficiency. They will have repeated pulmonary infections because they can't cough and clear secretions. They can have some feeding problems. And most of them develop a cardiomyopathy. They may have some intellectual impairment, and usually they die around 18 years of age. Patients with Duchenne's will have really high elevations of their creatine kinase into the tens of thousands, as you see there. The moms are the carriers, and they may have somewhat elevated CK, but obviously they're asymptomatic. The patients are also at risk for malignant hyperthermia. When they undergo anesthesia, they can have episodes of malignant hyperthermia. The EMG is helpful, but the best test is the molecular genetic diagnosis test done for Duchenne's. Management, you need all kinds of people to help you. You need nutrition, you need physical therapy, occupational therapy, you need psychological counseling in addition to the MDs. They need, heart failure needs to be treated, very vigorous treatment of pulmonary infections. They need machines to help them clear up their secretion. We'll use the vest that vibrates, we'll use bronchodilators, things like that. They obviously need nutrition and orthotic devices to help prevent some of the contractures.